ICLEAR gives a system, which people probably are doing a lot of these activities, but they're not systematized. So if you don't systematize something, bits get left. And I think another key element of this is working out who is the key person to talk to the patient. So it's not just the doctor or the lead nurse, or it might be the person who has the best relationship. So it's about being flexible in the approach, but making sure that there's this system behind it, so all the elements are covered, so that especially when it comes to the review, people know what's been spoken about before. Otherwise, how do you know what you're basing your review on? So again, this clear communication with the patient, the family, but also with the wider healthcare team is really important.
And in a lot of countries, that's going to be towards the GPs, so the general practitioners, the family doctors, who in some way are also going to link back to the hospital team. But what's important about that is we have some way of recording this information in these discussions in a way that sort of follows the patient over these different care settings, so that it's not a totally new conversation, a totally new trajectory of making decisions all over again every time the patient sees someone who maybe wasn't involved in a previous step of this ICLEAR process. But what we also hear very often is that this reflex to refer patients, for example, to the palliative home care system that we have is still very much focused on cancer. So in a way, this way that we have now of working that we're introducing with ICLEAR is also just raising this awareness across different disciplines and across care teams and follow-up teams, that these patients with advanced COPD really are a population that can benefit very strongly from having a palliative care aspect to the care that they receive on sort of an integrated level.
Yeah, and I think that's really important, that people don't get lost within all of this. And I think in the UK, when we were talking to our GPs or family doctors, when we talked about having a form to communicate with them, so we were going to document what has been said to the patient and break it down, then they were like, well, this would be amazing, because they're going into these consultations. They don't know what's really been said. They don't know what the goals of care are. They don't know what decisions and plans have been made. They're trying to infer it often from relatively brief discharge letters. So they then felt more able, from what they said in those workshops, that they could have a proper consultation with the patient where they had a shared understanding of what the aims were. Now, those aims could change, and that's why we have the review, so that we can keep reviewing, have the plans changed, so they can make really informed decisions about admission and what can an admission achieve. So I think it's really important to bring all this together. And I think the other thing, it will hopefully mean these things happen earlier. Rather than later, rather than just waiting for people who are really on an end-of-life pathway and being discharged home to die. That's not the aim of the study. It's catching people a lot earlier than that, so they can spend meaningful time at home, not being bounced into hospital.
I just want to maybe pick up on two things you mentioned, because one of the things you mentioned really is this information that's being lost otherwise between different care professionals. But what we also noticed, of course, was you can't rely on just patients being able to tell you all these different conversations that they've had. Not that patients don't want to be involved in their care, but what we found is these moments that they're admitted for an exacerbation is very chaotic. They don't feel well. There's a lot of different care professionals coming in, talking to them about all these different things that they need to remember. And if you ask them afterwards, what did you talk about? It's so much for them to retain. So there really needs to be a way to keep track of that and make sure that the patient has access to that and that follows the patient through their care trajectory. And also, maybe as a final thing, I wanted to pick in on the word that you said, meaningful. And what we realized as well is whatever the form it is that this intervention takes within different settings, what we really find is that having these conversations with patients is meaningful to care professionals and to patients and to their families. We have so much feedback already from teams who are really invested and interested in being able to work this way, because they really feel that palliative care is something that they can offer patients that will be meaningful to them. And from the teams that were already testing out this intervention when we were in the adaptation phase, we noticed that they took so much of that with them into their daily practice, and that stayed with them even when we implemented it for such a short time. So we really noticed that the impact that we're hoping to make is already starting to take hold in the teams that we're working with. So I think that's really promising.